So now we're going to have a look in more depth at how to manage head shaking. And I very much hope that, should I give this presentation again in a few years' time, I'll be able to give you better answers. At the moment, we can manage some and we can't manage many. And I know you're very well aware of that. So what are we going to look at? We're going to consider why we might be able to treat trigeminal-mediated head shaking, why it's hard to treat, have a very short, don't worry, very short, anatomy and function review. We're going to look at the challenges to objective assessment of response to treatment, and then we're going to cover published treatment options, those that might work, those that don't, and we'll touch very briefly on the future. And the future is certainly something that you can always talk to me about directly, because there's obviously various research plans that we can't share at the moment. So why might we be able to treat trigeminal-mediated head shaking? Well, as we said before, the nerve is sensitized, it fires at too low a threshold, and presumably this is because there's a switch that's been flicked and we don't know which switch and how it gets flicked, but it appears to be able to be flicked back naturally. Now 5% of horses seem to just spontaneously get better, and 25 to 64%, if you remember, that varied on your criteria, but went into some sort of seasonal remission, so either improved 64% or resolved 25% out of season. So we should be able to flick this switch if we only knew which switch and what flicked it. We've got a functional, not a structural abnormality. So there's nothing wrong with the nerve if you look at it under the microscope. Now there must be something wrong with it at a smaller than a microscope level, but if there was a great big hole in its myelin sheath, I think we'd be having a whole different conversation at this stage. So we might be able to do something about it, and that's some of the work behind that. Why is it hard to treat? Neuropathic pain. So neuropathic pain is really hard to treat. You don't do terribly well with neuropathic pain as a person. Never mind if you're a horse. We don't know why trigeminal nerve has become sensitized. We don't know how the trigeminal nerve has become sensitized. We don't know what's causing it. We don't quite know how that all fits in with the signs you see. And it might be that there's more than one cause for this that ends up looking the same, but in different horses there may be a different cause. And I think that's potentially quite likely, and that will make our lives much, much harder. Just a little reminder about anatomy. The nerve we're really interested there is the yellow one. And as you can see, it spends quite a lot of time tunnelled away inside the horse's head, which also leads to a few more challenges. So it's the largest sensory cranial nerve. One of those branches also has a bit of motor function, but the one we're really interested in is the maxillary nerve. That's the yellow one, and that's sensory to the lower eyelid, the maxillary teeth, the upper lip, the maxillary sinus, and the nose. And the signs that we see in these horses with trigeminal-mediated head shaking are mostly about the nose, aren't they? And that's the bit that's innervated by the maxillary nerve, and this lady is showing that quite nicely for us. She starts off twitching her muzzle and then she starts to head shake. And any proven head shaking treatment seems to work by reducing sensory input from the trigeminal nerve, and that was even before sensitization was known to occur, and we haven't known about that for very long at all. And anything that has worked, even if it was just tried to see just in case, or tried for a different reason or the wrong reason, perhaps like a Nosenet that was initially tried to see if it would stop pollen going up the nose, seems to work by reducing some sensation from that nerve, or at least sensory input to the brain. Now I mentioned this at the beginning that we'd look at this, other challenges to developing treatment. Now horses head shake, and they vary in severity from moment to moment, and also from day to day, week to week, month to month, and you know that. That one day the horse is a bit better, one day the horse is a bit worse, one moment the horse is a bit better, one moment the horse is a bit worse, and that means it's quite challenging to assess response to treatment, because especially if you're quite invested in it, you try something, you think I really want this to work, and of course you do, because you want your horse to get better. There ends up being about a 30% placebo effect, so you think your horse is better 30% more often than it is, and what we really need is an objective measure of head shaking to try and take that subjectiveness out of it, so that you can be sure that the horse has responded, because actually the longer you spend chasing a treatment that's not working, the more it costs you, and the more length of time that your horse is suffering pain for. So that's certainly something that I'm working on, and again can give you some information on that if you ask directly. Without that though, I class success as return to work at the previous level or above. That's still just evaluated by a person, which has its limitations, but I think just be very cautious of what you read on the internet. Be cautious of horses that the owner has diagnosed with trigeminal-mediated head shaking. We know that even if they really look like trigeminal-mediated head shakers, we'll find something else in 10%, and be very wary of, I think my horse is better, because we know there's a 30% placebo there. So at least try and get onto, does my horse do the work it used to do before he got ill? So I'll have a little look at treatments, and I was going to look at published treatments mostly. I slightly stray off piste, but mostly we'll look at published treatments. And first of all, we'll look at those with no proven efficacy, and then those with some proven efficacy. Now, there's lots and lots of unpublished treatments, and I'm happy to discuss those, but we can't put those in a presentation because you would be here forever. So treatments with no proven efficacy. So feed supplement, this was the Liverpool team that did this, and they did a double-blinded placebo-controlled trial. So the horses had supplement A, then they had a gap, then they had supplement B, and people took videos of them head shaking during that time and reported whether or not they thought the horse was better. Now, one of those was the real supplement, one of those was just ash actually, and nobody knew which was which until the end of this study. There was no improvement in the horses, no improvement at all, but there was a significant placebo effect. But both products, so it was evenly split between owners that thought their horse was better on A and thought their horse was better on B. But actually, when vets looked at the videos and just assessed the severity of head shaking without knowing whether the horse was on a supplement, off a supplement, and which supplement, because we took sort of 5 videos per horse, then there was no effect at all. So again, that just goes to prove the placebo effect. Now, this gonadotropin releasing hormone vaccine was tried quite sensibly, really, because of the thought that potentially more geldings are involved. And it was tried in 15 horses, but actually quite a lot of them had vaccination reactions, so it was stopped at that point in the study. And a third of owners, said that their horses felt a bit better. So I think that's again our third placebo effect. In actual fact, none of the horses were better. So although it was a sensible study to do, it didn't advance us in that way. Pulsed high-dose dexamethasone. A really sensible thing to do before you know that there's no pathology, and this was done, published in 2013, was before it was shown that there was no gross pathology in the nerve, is to see, well, is this nerve really inflamed? Can we treat it with very, very strong anti-inflammatories and see if it gets better? No, it made no difference at all. And now that we know there's no inflammation in the nerve, that actually makes entirely sense. There's no point in treating inflammation if you don't have it. But again, it was a sensible thing to do at the time, but it hasn't advanced us forward. This was an owner survey. So again, you're looking at an owner-reported diagnosis and owner-reported outcome. But they looked at 109 horses, so hopefully that would help reduce any impact of that. Even if you look at enough horses, you should get an answer. But they looked at 109 horses and nothing stood out. There was no particular treatment that was working, and a range of things were tried: antihistamines, antibiotics, corticosteroids, non-steroidal anti-inflammatory drugs, so things like bute, melatonin, chiropractic treatment, and acupuncture. So those are the things that are published that haven't worked. What's published that can work? So the Nosenet, that's the first one to try, and the vast majority of owners before they get to this stage would have tried a Nosenet, and I recommend trying 3 different varieties before you come, which is on the paperwork that you would get before an appointment. But why try them? They're cheap, they're non-invasive, they're risk-free, and you can compete at most levels. What results can you expect? Up to 70% relief in 25% of cases. Now, 75% of trigeminal-mediated head shakers are not going to respond, so that's going to be very disappointing. In the 25% that get better, 70% relief can be enough if you perhaps aren't too bad a head shaker, and maybe you don't compete at good level dressage, you're fine. But if you are a top dressage horse, even if you're fairly mild, if you're only 70% better, it may be that a Nosenet is not enough for you. So it will vary on a case-by-case basis. How does it work? Originally tried because they thought it would stop pollen going up the nose, and it doesn't. Pollen is very, very small. And actually doesn't seem to it doesn't seem to be the problem, although it may somehow be connected through the environment, but it's certainly not directly. How does it work? We think it's similar to gate control theory. What's gate control theory? The first thing you do when you bang your elbow is you clutch it and rub it, and it feels better. And those of you with small children will spend much time rubbing bumped heads and legs and all sorts to make them feel better. It's certainly something that I seem to spend a large amount of time doing. And so you rub knees and it does actually feel better, but the bruise is just as bad. And that's what this Nosenet is doing, is rubbing that nerve all the time, and then that helps stop the pain fibres from firing, because the other fibres are firing, and then it's called a gate at the spinal cord, but it stops the pain fibres firing. So that's why that feels better. But you will get a small number of horses who actually find a Nosenet vastly unpleasant, and actually they're probably experiencing more pain from having a Nosenet because they're so sensitised that actually the sensation of a Nosenet gives them pain itself. So all you can do is try, and where it works, that's great. So this little horse here, not too bad a head shaker compared to some that we've seen, but certainly not very happy and can't do her job. And with a Nosenet here, she's 70% better. She has a little twitch up this side, there we are. But she's really an awful lot better. Now, not published is adding in some covering to the eyes, so as well as the nose. So covering the eyes can help reduce stimulation of the ophthalmic branch, and it will work for a photic head shaker, which may be a subset of trigeminal-mediated head shaking, but it doesn't work for a lot of horses. Now, if the eye mask does work, you try tinted contact lenses if you need to compete somewhere that you can't use an eye mask, but tinted contact lenses are very expensive, so it's only for the few. I tend to find the eye mask isn't enough on its own, but you will get the odd individual that does respond. But try a full face mask where you've got the eyes and the nose covered, and again, it may not work, but it certainly doesn't hurt to try. And if we go back to our little mare with the Nosenet, if you add in the eye covering, she's just got a field fly mask on, nothing exciting, she's that much better still. So this is the type of horse that would benefit from contact lenses. Actually, this individual doesn't tolerate contact lenses, but he's managing his head shaking very well. He wears a mask at national competition, and internationally he is doing well enough to not need one, but we've certainly trialled tinted contact lenses with him. But so they're not a quick or easy fix, but we have used them with some success in some individuals who respond to just having their eyes covered alone. What about drugs? That would be your go-to as a person quite often if you've got neuropathic pain. What about in a horse? Now, what's published in horses is the use of two drugs, so cyproheptadine and carbamazepine used on their own or together. There's another drug that's used for neuropathic pain in the horse, but it's not been published for head shaking, and there is some anecdotal evidence that it can work in some individuals. There's also a bit of anecdotal evidence that potentially we need to use higher doses than is published for neuropathic pain in general in the horse. So a little bit watch the space on that one. But the problems with pharmaceuticals are in people with neuropathic pain, the drugs have inconsistent results. So some individuals with the same sort of history, the same condition will respond well to one drug and not to another, but someone else will respond well to a different drug and not to the same one. Others will respond well to none of them. So it's very, very variable between individuals and people. And we actually know at least how many tablets to give a person. Results can be short-lived, so they do actually sometimes use response, particularly to carbamazepine, for diagnosis. So if you have orofacial pain and they are concerned you may have trigeminal neuralgia as a person, one of the things they may try and do is give you a trial of carbamazepine and see if you are better, because if you are, then that sort of confirms a neuropathic pain, and maybe then you move on to a different treatment once it perhaps stops working. And some people have side effects such as drowsiness, and we need to be aware of that. Now, in trigeminal-mediated headshakers, the drugs have inconsistent results. So what we know from cipraheptadine and carbamazepine varies quite a lot. So again, it seems to be some individuals do well, some don't. Otherwise, the gabapentin hasn't been published in the horse. Again, results might be short-term. We don't know how many tablets to give a horse, or how often. So we do a best guess, but we're going to be worse at treating this than we are in people. Some horses can be affected by drowsiness, which I think you need to be very aware of, because are they safe to ride or handle? However, if you stop head shaking but are sleepy, then you then have to see if you can reduce the dose to a level that you are still not head shaking, but you're not sleepy. And after a few weeks, the sleepiness can wear off as a side effect as well. So those horses may be worth bearing with. And when I trial these drugs, I go high end of the dose rate, which can end up being very expensive, but there's no point in doing a low dose and going, oh, it doesn't work, but is that because I'm on a low dose? If you've got a high dose and it doesn't work, then you know it's not going to work. If it does work, but you're sleepy / it's really expensive, then you see how low you can go and see if you can stop the head shaking. So 2-week trials in appropriate cases, which is largely horses that are not intended for competition, because of course you can't compete on these. Some individuals can respond well. You've also got to have someone who can afford it, because it can get really expensive. So it can be done, but it's not the first reach to, as it perhaps would be with a human patient. What else is published? A little bit on homeopathy. So 20 horses were treated with homeopathy, and there's very little detail in this paper as to what was done. 15 horses had follow-up, and actually the vast majority of owners felt their horses were improved, but I think we at least need to consider the placebo effect there, on the robustness of feeling your horse is better as an outcome measure. I'm afraid I'm not a believer in homeopathy, but I guess it won't do harm given that you're not really giving anything. But yes, I wouldn't pursue this one. Sodium cromoglycate eye drops. Now this is a mast cell stabilizer, so it stops you producing lots of histamine in your eyes. And any of you who have a bit of hay fever, or me, allergic rhinitis to horses, and I end up with very runny, itchy eyes, this is a great drug. And it was effective in 3 seasonally affected horses and got them back to work, which suggested maybe allergic conjunctivitis was a cause of head shaking. But actually, if we look at this paper, we don't really know what signs these horses were showing or how they were investigated, and potentially these horses had allergic conjunctivitis, and therefore this treatment worked very, very well. So conventional, if that is a suitable word to use to describe allergy, is not the cause in the majority of head shaking cases, unfortunately. Well, maybe fortunately, because allergy is not easy to treat, but it isn't the cause. But if you want to try this, then trialing treatment is low risk. You can buy this drug just in the supermarket. But I don't use it very often, but I do use it for horses that maybe have particularly runny eyes, or rub their eyes, and I think it's worth a try. But I haven't been able to replicate the results there. What else is out there? Magnesium and boron. So over at University of Davis in California, they did some work on a herd of head shakers that they have, and they gave them oral magnesium citrate and boron supplementation, and that reduced head shaking. Now, just giving them some concentrate, so these horses were normally just fed on hay. If they gave them a bit of concentrate, they shook a bit less. They shook a bit less more. Is that a way of explaining it? If they had the magnesium and boron supplementation. Now, the boron is only there to make you absorb more magnesium, so it is getting them more magnesium-y that seems to help. Now, what we don't know is whether that's to do with the cause of head shaking. I suspect not, but we know that magnesium can help stabilize nerves, so it's certainly not wrong to supplement magnesium. But a few words of warning: you're not going to stop your horse head shaking by supplementing with magnesium. You may reduce the head shaking. I think it's important to do as part of a holistic approach, but I think you'd be very disappointed if you're expecting a cure, although obviously you might be lucky. How much magnesium do you give? Now, there are potential side effects, so I think you do have to, much as the temptation is, I know that I need to make my horse have more magnesium, I'm going to give it twice the manufacturer recommendations. I think you do have to follow the instructions on the pack. And then the next question is, what supplement? Now, if you're in the US, you can give there's a platinum performance supplement, which is the exact same mix that was used in the study. In the UK and the EU, you can't feed boron, which is not for any particular reason other than it's just not licensed because no one's done the paperwork really. But anyway, we can't feed boron, so you're stuck at just giving magnesium. And potentially what you could do is measure blood magnesium levels and perhaps adjust your dose accordingly. But that's all we can advise at the moment. I think it's important to do, but I don't think you're going to get a miracle cure. Often people say, well, surely if it's the nerve that's causing a problem, can't we stop the nerve firing? And we've just talked about how we like to reduce the amount of firing in the nerve, and that's what the Nosenet and the magnesium is doing, sort of calming everything down. Well, what about cutting the nerve? Now, Tim Mayer published this, and I think he was very visionary in addressing the nerve, because this was still far back at a time where we thought it was behaviour or allergies or goodness knows what. And people had talked about the nerve, but no one had... people actually sort of moved away from that as a potential cause. And he cut the nerve. Now, 3 out of 19 horses got better. There was lots of potential, side effects, and it's not something that we want to do because nerves try and grow back, and it does cause all sorts of problems. But it was still hugely useful for directing people towards this being a nerve problem. And when I worked at Liverpool, we tried to improve that surgery based on something that can be done in people, to see if we could try and stop the nerve firing so much but without causing so many side effects. And we had a fair success rate, but quite a lot of horses relapsed, and the main issue was again side effects. We thought that we would avoid neuroma formation with this operation, which I think we did, but we still ended up with significant side effects. And most horses rubbed their noses for a period of time after surgery, and would cause some self-trauma, like in this photograph. But this one was quite a mild one, so some of the self-trauma was really quite horrible. And again, it mostly short-term, a few weeks, and they got better. But 4 out of 58 horses had to be euthanized due to severity and or non-resolution of side effects. And obviously our outcomes for success weren't amazing. So I think we never like to do harm, and for now we wouldn't do this operation unless we were absolutely forced to, because we have some better solutions. So better solution, well, there's lots and lots of possible treatments for people with similar neuropathic pain syndromes, and no one good solution. And I think that's something we've got to be aware of, is that we're actually unlikely to find one size fits all treatment for trigeminal-mediated head shaking. But we already work with South Mid Hospital and the neurosurgeons there, and said, well, now we know it's sensitized, and then we did some work that showed that there was no gross pathology. So yeah, what would you do if it was a person? And there's lots of different things you try. Or could try, but one of the things that they will do in people with this type of problem, or similar type of problem, is percutaneous electrical nerve stimulation, which is neuromodulation, and the idea is that it trains the nerve to work normally again, but nobody knows how. So it's minimally invasive. It can be used for management of neuropathic pain in people, and there are blinded trials in people, so it can work in people for sure. Not everyone at all, but it can work in some people for sure. But no one knows why, and not knowing why is very frustrating, because then you don't know how to make it better, and you don't know why it's not working when it's working. So what do they do? In people, you place an electrically conductive probe over the nerve, and you stimulate it at various frequencies and voltages for a set period of time, and that's a sort of set algorithm that's been worked out following not a hugely scientific approach, but sort of based on what patients said worked. And anecdotally, probably rather than informal guidelines, you do 3, and then if it doesn't work, you move on and do something else. What was important to us is that people said that once the probe was in place, and they didn't like the probe going in, I get that, but then the procedure is quite pleasant. and there are no reported side effects other than a bruise at the site of probe insertion. So we had a go. So this is one of our first horses. This is Dude. He's one of my faves. Here's us him with the probe in, and if you watch him, he twitches, and then for 3 seconds, and then he doesn't twitch. And as a person, you feel a tingling sensation. Then you twitch again, and then you tingle. And there's our bit of kit, and that's the nerve over the infraorbital canal, which is really an access thing. So we found that it was safe, and it could be done under standing sedation. We really didn't know if we'd have to do this under anaesthesia or not, but you could do it under standing sedation. And we got 5 of 7 horses back to ridden work. So we published at that point, just to say, oh, hello, this might be something. But of course, we had a quite short follow-up on these horses. We didn't know how long we'd get them back to work for. So we expanded that trial. We looked at 168 horses treated across the UK and Europe, and that was over a sort of 4-5-year period. And we all used the same equipment and technique. So everyone was trained by Bristol, and that covered 530 procedures, and we published that. It came out in 2019, but was sort of formally published in 2020. How safe is it? So complications happened in 8%, and they were all transient except potentially one horse that may have got worse, but he had started head shaking only a couple of weeks before treatment. So it's difficult to know whether that was part of his disease course. Those are our complications, really nothing terribly exciting. One had a mild case of colic after the sedation. We had a little bit of hematoma formation from having a catheter. We had a bit of dermatitis from the scrub. You know, I was being very tough on what we count as a complication. 3 horses said, oh, no thanks, you're not doing that. And then the ones that we are more concerned about is this one. So 3.4% had a suspected neuritis, which is a nerve inflammation, and that was a worsening of signs that lasted a few days. It didn't continue apart from, say, potentially in one horse, but we're unsure of that one. Now, we did find that you could speed recovery if they gave steroid, if the horse was suitable for steroids. Obviously, very, very generous body conditioned horses perhaps wouldn't be suitable. And we did find, and this is one of the useful things about doing a study, is we did find that if they had neuritis, they tended to have it again at the next procedure. So it's actually a very small number of horses that have neuritis, but they will get it again next time. And what we found right at the end of the study was that if you pre-treated with steroid next time, that didn't appear to happen again. So if they do get some neuritis, then pre-treat them with steroid before their next procedure. But largely we don't think it's a huge concern, but it is the one to watch. So what did we find? You should do 3 procedures. If no remission after 3, you can do more, but I think with reducing odds of success. So at some point it may be sensible to say, you know, enough's enough, because you're probably not going to do a horse any harm, but you're certainly spending money and giving yourself some heartache. So I tend to say 3 procedures, but we will have the odd horse that we will try more on if they start to show some promising signs after 3 but are not completely better. After 3 procedures, now 53% of horses went into remission, so back to their work at their previous level. But the big but is for how long? So from 2 days, which is totally pointless, other than from a research point of view. It showed we did something, but it wasn't enough. To keep the horse going back into work for more than 2 days is clearly not going to be a solution for anybody. And others are 5 years ongoing, still they're fine. The average was 9.5 weeks remission. Now that's a bit unfair because half of the horses were still in remission at the time of follow-up. And I think the take-home message is you're unlikely to be average. You'll either have a short remission or a long one, or one in the middle, but it'll depend on the individual. So it's almost not that useful to look at the average. You have to look at just trying it and seeing in your own horse. So there's our graph there. So if you look at the middle line, so that's about half of horses there go into remission, and then you follow it, and the line drops down over time, and it drops down as horses start to head shake again. So if you last a year without head shaking, it seems that we can probably say you're cured, although that's still a bit of a jump, but you don't seem to start head shaking again for years. Obviously we can't be sure what will happen tomorrow, but you don't seem to head shake for several years, but you've got to get through to that year. So only 18% will manage to not head shake for a whole year. The others will start head shaking again, at which point you treat them again. And they usually go into remission after a fourth, but not always. There is a small drop-off of horses that stop responding, and they usually go into remission for longer, and the same pattern for a fifth and a sixth. But there is a small drop-off where it stops working. So knowing that it's worked before is not a guarantee that it will work again, although it does mean it's quite likely. There were no predictors. We looked at how old horses were, how long they'd been head shaking for, all sorts of things, and there was nothing that predicted likelihood of success. So all you can do is try it and see. So it's just to summarise the neuromodulation. I think until we know what causes head shaking, we're going to struggle to treat it, and we don't know how neuromodulation works. That makes improving it difficult. But EquiPENS neuromodulation is currently the safest procedure with the best results available for a horse where a Nosenet doesn't work, but I would really like to find something better. Moving on from there, electroacupuncture has been developed for use based on the work that we did on EquiPENS, and it also provides percutaneous stimulation of the nerve. And it was tried in 6 horses alongside face masks and Nosenet, and had a median remission time of 2.5 weeks. What's good about it is it seems to be cheaper and therefore more accessible, and the neuromodulation is not available all around the world. But obviously the data are 168 horses compared to 6. There's a very big difference in the quality of the data we've got on this. So I think if you've got the ability to use EquiPENS neuromodulation, then you should do that first. But if that's not available to you, then I think electroacupuncture is the thing to try. But I don't know that we can directly translate the success, albeit limited, of EquiPENS onto electroacupuncture. It may be that it is lower, but we're not sure. So in summary, I think be as sure as possible of a diagnosis. Feed concentrate if you're not already. Supplement magnesium. Depending where you are in the world, you may be able to add boron. But don't expect a cure from that. Try a Nosenet. Try 3 times. Add in a face mask. If that doesn't work, try EquiPENS. It may be then, if your horse is suitable for it, that we end up trialling different pharmaceuticals, but that would be the order that we would do it in. And I think we need to know more about the disease to move forwards, and it may be that if you come in for a consultation with your horse, that we will ask you to enrol on some kind of study as well. So just to finish up with a case, pretty severe trigeminal-mediated headshaker here. And here he is after his neuromodulation. And he has carried on for years, actually, and done really, really well. So it's always nice to finish on a nice one. And then just to finish up with contact details. Thank you very much.